Let's go back to addiction, this time to alcohol, a truly enormous problem for countries like Australia, and one of the most argued about mutual self-help programs, Alcoholics Anonymous, which has been shown to be effective in producing and maintaining abstinence in many people. Someone who's researched Alcoholics Anonymous in a very sober fashion is John Kelly, Director of the Addiction Recovery Management Service at Massachusetts General Hospital in Boston and Associate Professor of Psychiatry at Harvard Medical School. One of his more recent studies has been into the differences between how men and women benefit from AA.
This study is using data from a multi-site clinical trial involving 1,726 patients, about 2/3 men, 1/3 women, and they were followed up for between 1 and 3 years. And we found some very interesting differences between the way that men and women benefit from AA. Among men, where AA seemed to benefit them was to do with their social networks. So AA helped men stay sober by helping them to adopt sober friends, sober social contacts, and drop heavy drinkers from their network. The same was true of women.
Getting out of bad company.
Getting out of bad company, you could say. A risky company, yeah. The same was true of women, but only to about half the same degree.
So just with the men, it kind of gave them the guts to say, I don't need to see Joe anymore.
Exactly. Another way for men, again, related to this social risk factors for relapse, is that AA enhanced their confidence in their ability to cope with high-risk drinking situations. So this might be situations after work or sporting events, or they had confidence in their ability to be able to resist pressure to drink in those situations. That wasn't present for women, interestingly. Maybe because women aren't exposed to those kinds of social risks in this age range, which was largely between the ages of 30 and 50 years old. Where women differed, however, was they benefited more through the gains that they got from AA participation in enhancing their ability to cope with negative affect. So this was things like depression, anxiety, anger, and AA boosted their confidence in being able to cope with those without drinking.
So convincing you don't need alcohol as a crutch when you're having a bad day.
Yeah.
Now, both of those things are what clinical psychologists try to achieve with cognitive behavioural therapy in that situation. They're trying to teach people how to deal with risky situations, the fact that you don't need drugs when you're feeling low, and yet Alcoholics Anonymous isn't cognitive behavioural therapy.
Not on the surface, anyway.
What's going on in a meeting that gives them that confidence?
That's a good question, and we don't know the answer to that. From the psychotherapy literature, we know that these common processes of therapeutic change, things like coping skills and cognitive skills, they happen in many different types of therapies that ostensibly don't incorporate any of that language or explicit focus on those issues. And Alcoholics Anonymous has been shown, actually, and 12-step based treatments, professional treatments that are 12-step based, have been shown to increase coping skills and cognitive factors even when they're not explicitly prescribed or talked about.
What are the 12 steps?
Well, the 12 steps are 12 statements about how people initially recovered. It was describing a process dating back to the 1930s. They themselves kind of grew out of another group, which was called the Oxford Group, which was a precursor to AA back in the 1920s. And essentially it was about a kind of admitting you had a problem and then taking steps to do some self-inventory, to make amends to other people that you've harmed, and then to kind of work a daily program of recovery and helping others, which grew out of this initial group, which was the Oxford Group, which was really a Christianity group, but it was non-denominational. AA grew out of that because it was felt that that was too religious.
So what do you take from this in practical terms? Somebody's listening to us who is alcohol dependent, they're struggling. Are they going to go to a meeting? Are they going to go to a clinical psychologist? Going to go to the general practitioner and get a Camprosate? How do you get into the mix here and make a decision?
Well, I would say try all of the above. We know that addiction is multifactorial. There are many components to it. Recovery is very difficult. It's very difficult to change and maintain recovery over time. So I would say go to a clinical psychologist, go to your PCP, try a medication.
PCP being a primary care
practitioner. Give AA a try. One of the good things about AA is that it's free and it's widely available in the community. You can go as frequently or intensively for as long as you want. And as many studies now have shown, that it can enhance the chances of recovery and reduce hospitalization and healthcare costs.
And so from your clinical trial, though, you're going to get benefits from any kind of therapy, but AA is likely to promote continued abstinence.
It promotes continuous abstinence and it actually enhances the effects of other kinds of interventions. And that's what this particular study also showed, is that independent of what treatment you got, AA added to that in terms of adding more sober days. And
so it's not one or the other, you can do both.
You can do both, exactly. And that's what we recommend.
There's no debate anymore between controlled drinking and abstinence. The goal here is you've got to get off the drug.
Yeah, certainly in terms of alcohol dependence and definitely severe alcohol dependence, the chances of being able to control your drinking after meeting criteria for alcohol dependence are very low. People often do try to control their drinking for a while, and then they eventually come to the conclusion, in my clinical experience, that it's easier to abstain than it is to try and control it.
You're also you've got an extensive research program into young people, and the key here, of course, is if you're not using a drug to unhealthy levels by the end of adolescence, you're unlikely ever to.
Yeah, that's right. The highest risk for the onset of addiction is among teens and young adults. So now there's been a push in developing evidence-based practices for intervening with young people who develop drug and alcohol use disorders. We have a couple of studies now going on where we're developing treatments for those populations.
And one of the problems here, of course, is that whilst there are fairly well-proven treatments for quitting tobacco, alcohol, things like amphetamines and ice, the evidence base is pretty low.
There's a lot of general principles which we can draw on to treat different types of addiction which aren't specifically focused on a particular drug. As I mentioned, those common processes, we have common treatments which we know can affect the same parts of the brain, that dopamine pathway in the brain which is hijacked by drugs, whether it's alcohol, methamphetamine, cocaine, or opiates. Abstaining and then giving people skills to cope with triggers in the environment work for all kinds of different substances.
There's a recent study from the Netherlands looking at the pathways that kids take to alcohol use in adulthood, showing that behavioural disorders in young people are a strong predictor of a bad outcome. Getting into bad company, often people who share these conduct disorders with. To what extent do you introduce treatment for developmental disorders of youth?
That's a very good question. The earlier we can intervene and offset this potential risk, the better. The thing that you're alluding to, these externalizing behavioral problems, conduct disorder, impulse control, that are not the full manifestation of the disorder but are risk factors for it. There has been some very interesting, very early interventions, even as early as second or third grade, where they've actually done a program called the Good Behavior Program. And it was actually
in primary school.
This is in primary school, and shown that intervention actually predicts a lower incidence of substance use disorder 20 years later. Younger people typically are a little tougher to engage, in part because they haven't suffered as much of the negative consequences as their older adult counterparts have. But that's the point. We want to try and prevent that and offset the clinical course. What we do know from studies is that people who start the treatment process earlier, just like any other illness, the same is true with addiction. And so the earlier you can start the intervention, even though you might not get complete abstinence with young people, you started to alter, destabilize the addiction course. And that's part of the process and what we're aiming at.
John Kelly is Director of the Addiction Recovery Management Service at Massachusetts General Hospital in Boston, and he's also Associate Professor of Psychiatry at Harvard Medical School. I'm Norman Swan, and this has been The Health Report. I'll see you next time.